No problem.
I'll just say it.
No problem.
A very good evening, everyone. Welcome to iFocus Online, Lecture 228, number 15 in our series on Squint and Pediatric Ophthalmology. We are honored to have Professor Pradeep Sharma sir back with us with the part 2 of the expert summary, that is comprehensive evaluation of a patient with strabismus, the motor evaluation. I invite Professor Amitava sir to just introduce our speaker and welcome him.
Thank you, Shefali. Once again, it's a privilege to introduce Professor Pradeep Sharma, although I think he really needs no introduction at all. But since we have to go through it, he did his graduation and master's from the All India Institute of Medical Sciences back in late 79 and 82. He's the fellow of the National Academy of Medical Sciences since 2007. He did his fellowship for advanced training in strabismus in USA at the Jules Steins Eye Institute, Wills Eye Hospital, Philadelphia, and Richmond Eye Hospital. He was awarded by the International Strabismological Association in 2001. He's also the first Asian invited to deliver the NAP lecture by the American Association for Paediatric Ophthalmology and Strabismus in Vancouver in 2016. He's got the Achievement Award by the American Academy of Ophthalmology in 2017. And the prestigious Colonel Rangachari Gold Medal for the Best Scientific Paper back in 1984, and Dr. Athavale Award 2002 of the AIOS. He was awarded Dr. Baldev Singh Oration of NAMS, that's the National Academy of Medical Sciences, and named orations of 12 state ophthalmological societies, and iFocus H.K. Tiwari Golden Apple 2019. In addition, he is the visiting faculty in Orbis, and the international member of the American Association for Pediatric Ophthalmology and Strabismus, and International Strabismological Association member, Communications Committee of the IPOSC. He's also the chairman, Pediatric Ophthalmology and Strabismus of the AIOS Collegium for FICO, and the vice president of Ophthalmic Research Association of the RPC AIMS. He's the former president of SPOCI, that is the Strabismus and Pediatric Ophthalmological Society of India, and he has over 250 scientific articles in both national and international journals or chapters in books, and he's authored books too. And is a very popular book of his, that's Strabismus Simplified and Essentials of Ophthalmology. Over to you, sir.
Thank you, Dr. Amitava, for that great introduction. I would just present my moment. Is it? So this is the part 2 of the comprehensive evaluation of strabismus, and today we'll be talking about the motor part. And we move on here with a lighter note of reality check in strabismus. So there was a ship on the harbor, and it wasn't moving, wasn't working. Many engineers were called in, and they all tried their hands, but somehow it wouldn't work. Finally, a wise man was called. So he went around checking all the places, and then came to a place, and then he asked for a screwdriver, and he tightened one screw and said, okay, start the engine, and it started roaring. So then they asked, oh, that's great. So they said, what is your bill? He said, 1 lakh rupees. He said, what, 1 lakh rupees for tightening a screw? He said, no, dear, it's actually 99,999 for knowing which screw to tighten, and just 1 rupee I am charging for tightening the screw. That is similar to strabismus. Strabismus, the main part of the workup is knowing what to do. Otherwise, strabismus surgery is one of the simpler of things that we do. So we talked about the sensory evaluation in the last talk, and today we'll be completing the second part with the motor evaluation. We talked about the fact that we have the 9 gazes and 12 extraocular muscles that are working like the planets in the 12 houses, disturbing the thing. So these different gaze positions, we are all aware. We'll go back to this, that basically, as we all know, it can be horizontal, iso, exo, vertical, hyper, hypo, torsional, excyclotropia, encyclotropia. And of course, we'll also have to know whether it's a commitant squint or a incommitant squint, spastic, paralytic, or restrictive. The basic recipe that I suggest is OCIPE. O for observation, C for confirmation, I for inferring, P for planning, and E for executing. So this 5-pronged approach is what I am suggesting usually, that we should have very good observation, because when we are dealing with children, they give us little time for observing. So you have to be very sharp observer. And then you do basic simple tests which will confirm that observation. And then you can infer in your mind what to do and finally plan and execute. Now let's say this child, and you look at the top picture, it looks like an esotropia. But is it really an esotropia? We have to keep in mind that there can be pseudo-esotropia, an apparent squint. Why? Because of the appearance, and this is because of a large telecanthus, you can see here, and the epicanthic fold, which are hiding the medial side of the conjunctiva and making the eye appearing eso. More so, on looking on the side, this becomes still more problematic, that the eye appears eso. Not only eso, sometimes it will also appear as if having an inferior oblique overaction or elevation in adduction. So this is what appears on the left side gaze. So be aware of this. We'll talk about how to distinguish it from a true esotropia. The middle picture is showing you another situation in which the eye is appearing as eso. This is because of a larger palpebral aperture, an euroblephron. And again, these people will have an appearance of an esotropia. But if you look carefully, both the corneal reflexes are right in the center or symmetrically placed. And if you do a cover test, you will be able to distinguish. The third bottom picture is again showing you a look of a exotropia now. Now we're coming to the exo from eso. Here there is an exotropia. Now whether it is a true or a pseudo-exotropia, it could be because of a macular drag, as you see in the picture here. If there is a drag macula, although the person is looking from the fovea or the macula, it will appear as if there is an exotropia. Now these cases of resolved or partially regressed ROPs are going to have this presentation, and many a times confuse us that there is a squint. We should not jump to operate them because that's a pseudo-exotropia. Pseudo-exotropia can also be because of angle kappa. Now, what is angle kappa? We talked about some time back also earlier, that it is an angle between the visual axis, that is the point line joining the fovea and the fixation point, as you see on the schematic picture on the left hand side, and the angle that it makes with the pupillary axis. That is, the angle made at the pupillary plane actually is going to be the angle lambda, but the routine thing we use usually the angle kappa, which is not much different, which is supposed to be at the nodal point, but the lambda and kappa may be used more or less synonymously. These can be measured on the synoptophore by using special slides. And now with the interest of the refractive surgeons being more on the angle kappa, there are utilization of the even UBM and the corneal topography, which will help in finding out the angle kappa. The size of the angle kappa may be in the emmetropic eyes around 5 degrees, but hypermetropic eyes are more plus, 7.5 is the average, and the myopic eyes are negative angle kappa, and they may even appear to have a pseudo-esotropia. So we come to the second part, that how do we do simple tests to distinguish between the observation that we made. This is a cover test. If you have nothing else, just use your thumb, and the child is looking straight. You cover the eye, which appears to you that, okay, is it a true or a pseudo squint? And if you cover one eye, the other eye doesn't move, and then you cover the other eye, both the eyes are looking straight. It means that this is a true. There is no deviation in this, and there is it was only a pseudo-esotropia. Now, this is another case in which if you see the left eye appears to be esotropic, you cover the right eye and you can see that the left eye has centered, it is moved out. And so this is a true esotropia. Now we'll see this on a video. video, and you'll see here this boy has an esotropia. If you cover the right eye, the left eye has moved. So this is as simple as possible, that you just need to cover the straight eye and look for the movement of the other eye to confirm that there is a true or an apparent squint. This is another girl who has the eyes appearing straight. Now, if the eyes are appearing straight and you're not doubting that there is any squint, what you need to do is find out if there is a latent squint or a hidden squint. And for this, we do a cover-uncover test. So what we mean here is that you will cover the eye, nothing would happen because there is no manifest squint. But if you uncover, there will be something that will be seen. Now look at this video. You cover the left eye, nothing moved in the right eye, but now behind the cover, the eye is dissociated. There was an exo, look here, and then it has fused again. So this is an intermittent divergent squint. A latent exotropia is there in the right eye, and then it fuses back. So this is the cover, and then your main observation is coming on uncover. And how much time it takes to recover is another part of the assessment, that if there is a slow recovery, it means there is a poor fusion. This is another girl who has an intermittent divergent squint. Eyes appear straight, breaks for distance, sometimes on spontaneously. But when you cover this eye, now you see this left eye has gone out and it recovers. Now you may use prisms to neutralize and see whether it is getting fully neutralized, and then you can do the test for finding out the deviation which is there. Now here, the second part, you just use prisms and then keep on doing the cover test. We'll talk about this more. You may use the prism bar cover test, which is better than Hirschberg's, which is shown on the right side. And the Hirschberg's is only to be used in situations like very small children who do not allow the prism bar to be placed in front of their eyes. Otherwise, for all strabismus surgery purpose, a prism bar or loose prisms is the method of measuring the deviation. So there may be two types of prism cover test that we may do: the simultaneous prism cover test and the alternate prism cover test. So what is the difference between the two? In the simultaneous prism cover test, we are allowing the eyes to be fused again. So this is a true measure of only tropia. Whereas an alternate prism cover test, which you keep on alternating the occluder between the two eyes and never letting the two eyes to fuse in between, is also going to measure a phoria. Now this is a child. Now he is having an esotropia. We had seen earlier also. And now we bring a prism bar and keep on doing the cover test. But each time you notice, we are just covering the right eye and allowing both the eyes to regain their fusion. So, and then at the point where there is no further movement, we say, okay, now this is the neutralizing point, and this much amount of esotropia is there. So here it appears that it's about 35 prisms of ESO, which is there on measurement. Here there is an alternate cover test, prism cover test, and here it will also measure a phoria which is associated. Now you keep on alternating between the two eyes, not letting a chance to the person to see with both the eyes. And if there is a difference between the tropia with an additional phoria being there, then you will get a larger measurement on this examination. If it's the same, there is no hidden squint. People who have a poor vision in one eye cannot be tested on the basis of the alternate or prism cover test, because they will not be having vision enough to fixate. So in such cases, what you do is a Krimsky test, or rather preferably a reverse Krimsky or modified Krimsky. Now Krimsky test was that we are going to put the prisms over the eye which is having poor vision, whereas the reverse Krimsky, you're going to put the prisms over the good eye so that we can neutralize. And what you see here on the left hand side picture, there is an exotropia in the left eye. The good eye is the right eye. I put the prism of 45 prisms over the right eye, and you can see the left eye has got centered. And here we can easily see the prism, the corneal reflex. So it's better to use the reverse Krimsky, because the good eye can be easily use the prism in front, and that will be a better determinant. Remember, whenever we have to add prisms, if there is a larger than 45, we do not stack the prism one over the other. The 2 plus 2 is not equal to 4 in usage of prisms, but 2 plus 2 can become 5. And this is very nicely shown by Kushner in his book. You can see the top and the bottom pictures. The 20 and 20 prisms are giving much more deviation when stacked over one another than the 40 prisms or the lower half of the thing. So whenever we have to add prisms, we would split the prism between the two eyes. Okay. When we have high plus or high minus glasses being used for spectacle correction, and we have to measure the deviation, remember there will be an induced prismatic effect because of the high plus or high minus lenses. And this is definitely very significant when the deviation is more than 20 prism diopters and when the glasses power is more than 5 diopters for either the plus or minus correction. And there is no way but to resort to either putting a contact lens in place of that, which is not going to be very feasible. So what we normally do is use the nomograms or the tables which are there in the books. Like this is a table from Rosenbaum's book, which is used for correction of high plus. On one side, you see the measured tropia, and on top there is an actual deviation. And you can see what will be the, for each plus correction that you see, the higher the plus correction, like if it goes to plus 30, you will see that there will be a measured tropia which will become much different. So here 5 prism diopters becomes 20. So there's an addition of plus 15. So be careful about this measurement. Similarly, the high myopic prismatic effect can be corrected for our purpose of surgery when we are going to take the measurements with this by these correction factors. The other aspect of the deviation is the torsion. Now, for torsion, if you look into the fundus, you can easily see the foveal relationship with the disc. And what we say classically is that the fovea is supposed to lie between two horizontal lines, the one line passing through the lower pole of the disc and the other horizontal line passing through the junction of upper 2/3 and lower 1/3 of the disc. You can see the upper, on the left-hand side, there is an extorsion because of an inferior oblique overaction. The fovea is much below the disc horizontal line. And after the surgery, you can see the fovea has come into the center of the two horizontal lines. We can also see it on the indirect ophthalmoscopy or fundus photography and use a protractor to measure the torsion which is there. Even a blind spot charting with the head maintained to be straight with the help of a spirit level. And that means there is no head tilting at the time of charting the fields. You can see the blind spot gets shifted if there is a torsion of the eye. So measurement of torsion can also be done subjectively or objectively. We had talked about the objective ways by using the indirect ophthalmoscopy or fundus photography. Now subjectively, you can measure the torsion by using the diplopia charting, Lancaster red-green chart, double Maddox rod as shown on the picture on the side, the Bogolny's loose glasses in front of the two eyes, synoptophore with after image slides, or Polaroid stereo projector for measuring the torsion. Intraoperatively, we can also use the iridograms, or even on the slit lamp, we can take pictures of the iris and let us know the pre and post changes in the torsion. Now, this is showing you the double Maddox rod. You can see the tilt which is seen on the bottom line and becomes corrected when you move the one of the Maddox rod, and that much amount of correction which we have to make will tell us about the torsion which is there. When there is no deviation, we may induce a deviation to separate the two horizontal lines by putting a base down prism as is shown in this illustration. Whenever there is an uncorrected refractive error, the child needs to be given correction. If he is not given a correction, he will have two possible responses. If he is very keen person to see clear, he will use his accommodation and have an accommodative esotropia. On the other hand, if he is a lazy kind, he may not accommodate, but keep on having the blurred image in both the eyes and end up having a bilateral ametropic amblyopia. So we may have these situations. Now, this is an accommodative esotropia. He has a right eye esotropia. If you correct him fully, and if it's a fully accommodative esotrope, then he would have straight eyes with this full correction as per the cycloplegic refraction. If there is a extra convergence excess, how do we know that? Now, what you see on the left-hand side pictures, the person is having esotropia. You give glasses for distance fixation. The eyes are straight. The moment you bring an accommodative target, now mind you, don't use a torch, but an accommodative target to make him see at near. And you can see that the right eye has started having an esotropia. Now this is because of a convergence excess esotropia, because of the excess accommodation that is required for near fixation. And this would indicate that there is a high AC by A ratio, and he or she will require a bifocal correction to correct that. So if the bifocals have to be given, mind you that the bifocal should be bisecting the pupil and not improperly given like in the upper picture, but it should be the executive bifocals which are bisecting the pupil, letting the child see through the lower segment for near objects. Now here you have a partially accommodative esotropia. Now what do you see here? The child is having an esotropia. You give the correction. For distance fixation also, here there is an esotropia still left over. So if you have for distance fixation, in spite of the distance correction, an esotropia which is left over, and with full correction that we have done, that would mean that this is a partially accommodative esotrope having a non-accommodative component in addition to the accommodative component which is getting corrected with glasses. When we have to measure the AC by A ratio, we had talked about this in one of the earlier talks, that you can do it by either the heterophoria method, that means you measure the deviations for distance fixation at 6 meters and a near for 33 centimeters, and we use the IPD because that will be the convergence that he will have to in addition do, and that will be used in our calculation, a 5.5 IPD with the deviation that you measure for distance and for near, and that will give you how much is the AC by A ratio. Similarly, you can use the gradient method. In this case, you are doing it at the same fixation distance, and so the IPD is not required because that is the common factor, and you are only changing the glasses, and the amount of accommodative requirement will be based on the amount of glasses that you give, a -2 or a +3 to relax the accommodation. So if you have a divergence excess, that means for distance fixation, the measurements are different, and for near, the measurements are different. We will say there is a near distance disparity if it is more than 15 prisms or more. So up to 10 prisms, you may take it as within the basic ESO or EXO. Otherwise, it's a divergence excess or a convergence insufficiency EXO, as you see here. Or there may be a convergence excess esotropia. Now, coming to another aspect of measurement is the looking for up and down gazes. Now, here you see the middle picture is showing you an exotropia. But the moment you make the person to look up, and how much up? It's 25 degrees up. And you can see there is a exo which is widening. The eyes are widening. And on looking down, which is 35 degrees down, there is a collapsing of the exo. So it is more like a alphabetic V pattern. If you see all the three pictures in consonance, it is a V pattern exotropia. V because of the divergence happening in up gaze, and exo because of the primary position deviation measurement being outward. So on the other hand, now you have here a pattern. Now you see the ESO is there in the primary position and becomes more ESO in up gaze and less ESO or almost ortho in down gaze. So this is an A pattern esotropia. The difference between the up and down gazes for V pattern, we take it as 15 prism diopter minimum difference to make it significant V pattern. Whereas for A pattern, we take it just as 10 prism diopters to differentiate between the up and down gazes. Up that is taken as 25 degrees and down gaze measurement 35 degrees looking down. So these are the measurements that we'll take. You may take the help of mirror marked on the sides as a cephalodiviometer, or you may use a scale and protractor on the side of the person to ensure that you are having a reliable 25 degrees and 35 degrees head positions. So when we have the A and B patterns, then we are going to look for associated oblique overactions, if any. So for V patterns, you are going to explore the inferior oblique overaction, and for A pattern, you will look for superior oblique overaction. Obviously, there would be a corroborating underaction of these other oblique muscles. Now here you get the example of the V exotropia. What you see here on the side gazes, on adduction, there is an hypertropia of each eye and becomes maximum on the tertiary position. That means looking up on the left and looking up on the right. And as you can see with the blue arrows, there is a hypertropia of the adducting eye. So nowadays we call it as over elevation in adduction rather than inferior oblique overaction. That is what is better nomenclature, because we are just having an observation of elevation in adduction. We are not sure whether it is because of inferior oblique overaction, which may be more or less many a times true. So this is a V pattern with inferior oblique overaction or over elevation in adduction. Here you have another case in which there is a V pattern, but if you look carefully, you don't find the over elevation in adduction. So there is no inferior oblique overaction in spite of a significant V pattern. So there can be a V pattern without significant overactions of the inferior oblique. Similarly, there can be A patterns. Now here you have A exotropia. And if you see, there is a, you can see the depression, over depression of the adducting eye in the right eye as well as the left eye, on looking down on the right and looking down on the left. Can you all see that? So this is a situation in which there is an A pattern exotropia with bilateral superior oblique overaction. So your observation is important here. And how do you confirm? A cover test. If you do a cover test in these tertiary positions, you will confirm that yes, this is truly a over elevation or under or over depression of the eyes. For the superior oblique overaction, you look for superior limbus, that means for depression. And for inferior oblique overaction, you look for the inferior limbus rather than the amount of cornea which is covered. Here you have an A pattern esotropia without superior oblique overaction or without the over depression in down gazes. So these cases are little different. Similarly, you may have asymmetric over elevation in the two eyes. Here you can see left is much more over elevating, or inferior oblique overaction is much more in the left eye compared to the right eye. So if we make this observation and confirm, we would take this into account in our planning and execution of doing more surgery of the inferior oblique weakening in the left eye compared to the right eye. So management of AV patterns, we would take this into account. If the pattern is significant, but obliques are not significant, we are not going to weaken the obliques, but just shift the horizontal recti vertically, upshift or downshift. For V pattern, we are shifting the medial rectus downwards towards the apex of the V. And for an A pattern, again, medial rectus is shifted upwards towards the apex of the A. The lateral rectus are in the opposite direction. But if there is a significant elevation, over elevation, over depression indicating oblique overaction, we would have to weaken the obliques in addition to the horizontal surgery. The measurement would let us know how much surgery to do. The horizontal measurement will let us know how much is the horizontal recession and resection that we'll do. But for collapse on A and B pattern, we would have to go by either the shifting vertically of the horizontal recti if there is no inferior oblique overaction or superior oblique overaction. But if they are there, then we'll have to do the simultaneous surgery on the obliques. Now, this situation, there is an ortho in the primary position, but there is an over elevation in both right and the left eye, indicating a bilateral inferior oblique overaction, indicating a pure V pattern. There is an ESO in down gaze, see that, and exo in up gaze, and ortho in primary position. So this is a situation in which you do not do any horizontal muscle surgery and just the inferior oblique weakening of both the eyes, and you can correct the ortho maintained, exo corrected in up gaze, ESO corrected in down gaze, as well as the over elevations corrected in both the eyes. So we go by simple measurements of PVCT, but what we have to take care, now just jot down these points, different inferences of measuring on PVCT. First is difference between the distance and near fixation we talked about. For esotropia, basic, if there is no difference between near and distance disparity. If there is more ESO in the near, then it is convergence excess esotropia. If the ESO is more for distance, we call it a divergence insufficiency esotropia. Similarly, exotropia, if there is no near distance disparity, it's a basic exotropia. But if there is more exo in near, then it is a convergence insufficiency exotropia. But if there is more exo distance fixation, it's a divergence excess. Second measurement we will take is deviations in the 9 different gazes. And this will indicate if horizontal gazes you have an incompetence, or for vertical squints, the vertical gazes incompetence will be picked up. So we will then be guided to do whether it's a paralytic, restrictive, or spastic deviation. The third component that you have to keep in mind is looking up gaze and down gaze. Up gaze 25 degrees, down gaze 35 degrees for looking for associated A and B patterns, which are also known as vertically concomitant, horizontally concomitant squints. The fourth component you have to remember is deviations with each eye fixing for primary and secondary deviation in cases of paralytic squint. So you all know that if there is a paralytic eye, and we will be talking about paralytic strabismus in subsequent lectures in more detail, the measurements of each eye fixing are going to be different. And this helps us in knowing if there is a paralytic squint. The fifth measurement which you have to keep in mind is subjectively or objectively. Now, if you measure it with the help of PBCT, you are doing an objective measurement. But if you measure with the help of Bogolny glasses or the Maddox rod and do a subjective measurement, it will give you a different measurement if there is an abnormal retinal correspondence. But if both are same, it's a normal retinal correspondence. The sixth measurement is going to differentiate after a prolonged cover, and that will differentiate a true divergence excess from a simulated divergence excess in cases of exotropia, and that is because of the Scobie's phenomenon, or the proximal convergence being the variable. And the seventh measurement is deviations with and without glasses, the basic versus dynamic that we talked about. First of all, the accommodative esotropia, the accommodative hyperaccommodative ratio. Now we also have another thing to look for, and that is the DVD. Now look here, this is a translucent occluder, and what had happened behind the occluder, you can see the eye is drifting up, and when we remove it, slowly drifts back. Can you see this? This is another case with the Spillman occluder. The eyes are in the upper picture straight, but they put this Spillman occluder, the right eye drifts up, and when you remove, it slowly comes back. Now, these are cases of dissociated vertical deviations, and the deviation, you have to see how hypertropic they are both in abduction and adduction. Now see here, this is again a case of DVD. The left side, you see a DVD which is latent. So on both the eyes, you can see they are at the same level. But the moment in the middle picture I cover with the Spillman occluder, you can see the left eye has gone up. So there is a manifestation happening of the dissociated vertical deviation in the left eye. And when I put a graded density filter bar in front of the right eye and make it more and more dense, so what I'm doing is making the light sense passing through the right eye less and less. And you can see the left eye, which was drifting up, comes back to normal position. So this is a classic sign of the fact that it's a DVD which is having a difference between the light dissociation of the two eyes. If you may have a DVD, you have to look for associated inferior oblique overactions or superior oblique overactions. Now this girl has inferior oblique overaction. You can see that the hypertropia is much more in the adduction compared to abduction. And if that is there, then we have to keep that as a note. And when we plan a surgery, we would be doing a surgery on the inferior oblique to correct the DVD. We will have a subsequent lecture on paralytic strabismus. So I will not go into details, but just to hint that we have special tests which we'll be doing, like Lee's charting, Hess charting for paralytic strabismus, diplopia charting, like in this case of left lateral rectus palsy, or the binocular fields of fixation, the diplopia free fields. Here again, we have the diplopia free fields which have been charted progressively to tell us what is the change which is happening. And then just a glimpse of what we'll be covering in subsequent lectures about the management. So we have basically the non-surgical management and the surgical management which is there. In the non-surgical, we have first of all the glasses, and remember even the hyperops gain in exotropia also. Amblyopia therapy is the second component of non-surgical management. Orthoptic exercises will be very helpful in cases which have convergence insufficiency. You may do either on the synoptophore or the sustenance exercises with the help of pencil push-ups and the prism bar stereoscope exercises. Then we have the over-minus lenses, which is part of the non-surgical management. And of course, the prisms which may be used either as ground prisms or Fresnel prisms. Like here you have a child having an esotropia, and with the 24 prism adapter base out Fresnel prisms, you can see the eyes have got corrected. When we are doing the fusional convergence exercises, we should be making the child aware of physiological diplopia. Otherwise, he would be just doing pencil push-ups, and that will only help his biceps and not improve his convergence, because he would be probably using only one eye and not be aware of the other eye at all. So you need to make him aware of the physiological diplopia. Over minus lenses and IDS again are very helpful as a temporizing measure for short terms. In strabismus surgery, just as a glimpse, we may have different procedures: the recession for weakening, conventional or hangback or adjustable, and the retroequatorial myopexy or a Farden procedure to add on to the effect, and the marginal myotomies in resurgeries. And for strengthening, we have resection or advancement, plication or double breasting or cinching, and tucking for the superior oblique, and transposition of other muscles. It's important that we do all this assessment early, and we need to have an early alignment. And this case history of this child born straight when he was newborn and starts turning esotropic at around 3 months age, and then he's given proper correction glasses, and still in spite of the plus correction, he has a brighter reflex of Bruckner's in the left eye, indicating at 6 months an esotropia which is not getting corrected with glasses. So surgery is done at the age of 6 months by his father, Dr. Kenneth Wright, and you see that the eyes are straightened early at 6 months onwards, and he happens to develop normal stereopsis. That is Dr. Kenneth Wright smiling along with me in a selfie. Timing of surgery for exotropia is important. If it's an intermittent, we can keep a wait and watch and observe for the distance and near stereopsis and the control by Newcastle scoring. Again, we'll be having subsequent lectures to talk about in more detail. But remember, a constant exotropia is no lesser evil than esotropia. So we may have to rectify them in good time. So the critical periods that we always talk about, 4 to 6 weeks, like the favorite numbers in cricket. Congenital cataract, we need to take care of them by 4 to 6 weeks. 4 to 6 months infantile esotropia, 4 to 6 years for intermittent exotropias, nystagmus, refractive error, or whatever is disturbing the binocular vision potential. Timing is everything. Timing is important for any game or in life. This child having a constant exotropia early enough has to be operated at the age of 9 months itself. And you can see here that we can restore his binocular vision so that he is having the gaze corrected. And so with this, I would like to end my talk. Just to spread the mission of binocular vision being spread, the pursuit of stereopsis, spreading sight and happiness for kids the world across, maintaining the stereopsis and restoring the loss. This is what our pursuit is, and we all need the help of each and every one of you. So keep working for the children. Thank you so much for all this opportunity that you've given me. Thanks a lot.
Thank you so much, sir. It's always a pleasure to listen to your talks. Amitava, sir, any words from you?
No, once again, it was, as always, absolutely comprehensive. And there's little to add, except one or two things which I tell my postgraduates is, torch is usually not a good target. It's not an accommodative target. But everybody tends to pick up the torch at the first instance because they start with Hirschberg and then they expect everything to happen with the torch. But it certainly is needed for ocular movements. So for ocular movements, certainly a torch should be used. Otherwise, you should have toys or some small targets all the time, because the children need to have a resolving target. They need to accommodate. The human people don't clarify a light, so they don't accommodate for light. So you don't get the exact picture unless you have accommodating targets.
That's a good point, sir.
You should use the accommodative targets. Like toys would be still better than torch, because sometimes, and especially nowadays, the torches I find are having these LEDs bulbs, which are very bright, and they are actually forcing the child to look elsewhere. So you may have to use a filter or just use your fingers so that the red light is visible through the thing, through your fingers, that may be better, because the LED torches are too glaring. Even I cannot stand it. So
absolutely, so it's very right. So these torches are extremely bright. Even if they come in tiny sizes, they are very bright. I sometimes put it on my students' eyes, and then they all feel the glare. And then I tell them, don't put it directly on the eyes. You can put it on the chin. Enough rays go onto the eyes, and you can still see all your Hirschberg reflexes. So you don't have to put it bang onto the eyes now.
Good point, sir. I think we can take the questions from our portals. First one is, why do we specifically measure at 25 degrees in up gaze and 35 degree in down gaze for pattern strabismus? Like, why those specific degrees?
So basically, we want to have a substantial difference. So initially, it was 25 degrees up and 25 degrees down. That was done. Although there have been variable, if you go in the history of it, some people were doing 15 degrees up, 15 degrees down, but it was found that we are missing some V and A patterns. So we need to do 25 degrees up and 35 degrees down. Now, why more for down? Because if you see, looking down, we have to be more careful of the A pattern showing up. We don't want to miss. If it is 25 degrees, the floor would be missed. So if a person is breaking on looking down at 35 degrees, he will be missing the divergence which is happening at 35 degrees, or in walking, he will have a trouble. So you will miss some A patterns, A exos, if you are doing only at 25 and 25. So it is preferable to use 25 degrees up, because up we don't see so much, but 35 degrees down. Down gazes are more important than up gazes for the normal life. So whenever we are correcting also, we say always focus on the primary position and down gaze. If these are the two important gazes, if you have to choose between the 9.
So anything you would like to add, Amitava sir?
No. This is absolutely right.
Yes, sir. So next one is there a rationale in choosing either a prism bar versus loose prisms while performing PBCT?
See, prism bar is going to be more handy because you can slide it easily up and down. So it saves time. So, and usually you can go from, let's say 2 prisms, or 1 prism actually is also there in one of the prism bar. So 1 prism to 40 prisms on the prism bar. Most of the prism bars may have little variation, but 1 to 40 you may be able to go. But if you go loose prisms, you can add on. So if you have to do more measurement than 40, then you use the loose prism over the other eye and you can add up. So you have loose prisms of 30 and 45, you can easily go up to 40 plus 45, 85 prisms. So loose prisms are used as, in addition, the prism bar is used for the measurements in the graded fashion. As far as putting them, I mean, if there is a question that you have to put the loose prisms in the Prentice position, but the prism bar is having gradation on the frontal position. So in that, there is not much problem. But if you're using loose prisms, if there are these plastic prisms, you have to use them in the frontal position. Otherwise, there will be an error introduced. So that's another problem with the loose prism, that you have to be careful if they are glass prisms or the plastic prisms, because the plastic prisms have been graded in the frontal placement, whereas the glass prisms were graded in the Prentice position. So there will be a slight error in there.
But nothing to do, accuracy wise, both of them will work, right, sir?
Yeah.
That accuracy wise, you have to keep the loose prisms in these particular positions, but the prism bars are going to give you accurate measurements irrespective.
Yes. Next one is, while performing PBCT in an eye with both horizontal and vertical deviation, why is that we neutralize the horizontal deviation first?
If the horizontal deviation is the dominant one, you should neutralize that first. But that doesn't always be true. If there is purely a vertical deviation, or it's majorly a vertical deviation, you would neutralize the vertical first and then go for the horizontal. Because unless you measure the main deviation, you won't be able to accurately measure the other deviation. So if you have neutralized the horizontal, then you will start seeing that vertical which is left. But in a large horizontal, you will miss small vertical deviations. So unless you neutralize the horizontal, you will not be able to find out if there is any vertical deviation. So that's the reason that we'll first neutralize the predominant deviation which is there. Mostly it's horizontal, and then we subsequently do the vertical deviation neutralization.
But say if in a given case you have the vertical also 20 and horizontal also 20, the math doesn't change. I mean, you can then do the vertical and then follow it with the horizontal. or do the horizontal or then the vertical. But usually you need to, like Sir's pointed out, knock off the larger deviation to catch a smaller, one which is at right angles to it.
Exactly.
So the next one is, how do we decide on ocular dominance while performing the cover-uncover test?
The cover-uncover test is telling you between the two eyes. So you'll do for both the eyes. For dominance, you would have to do some other tests. Like the Miles test is there. You can use a pin, a card with a hole, and ask the person to read some letters. And obviously, a person will put it in front of his dominant eye. So, or you can ask him to look through, let's say, what we call that, a tunnel. You can give him a rolled paper and ask him to look some distant object. He will automatically bring it over his dominant eye. So you can do that. So these are the tests which are done in addition to no dominance of the eye. But cover-uncover test you will do for each eye. Correct?
I'm not sure, but if the question was whether it's an overaction or while testing in strabismus, if there is an overaction of one eye or an underaction of the other eye. I'm not sure, but yeah, as far as if the question has dominance,
yes, sir. So how do we decide on ocular dominance while performing the cover-uncover?
Fine, then we've got the answer to that. Fair enough.
Can you elaborate on objective measurement of abnormal head posture?
Okay, so if you have to measure the head posture, this will be usually going to be relevant in cases of, let's say, a nystagmus person which is having a head posture, anomalous head posture, or a paralytic squint who may be having a head posture. So what we do is we use a scale and a protractor. On the top of the head, if you put a protractor and aligning the 90 degrees axis with the sagittal axis, and then ask him to fixate. And if he has a head posture, he would have the visual axis, which will be at an angle with the sagittal axis. So on the protractor on the top, the angle which is made between the sagittal axis and the visual axis will tell you the head posture. So you can use either a geometric protractor, or nowadays you have this protractor app in your smartphone. That also is very simple thing. Many things are now all in your smartphone.
Otherwise, from a stationery shop, especially if you're in a university kind of an area, you can get small goniometers. We have metal ones also and larger ones of plastic. So they already have an inbuilt protractor, and they have a base scale and a scale which moves around with an arrow. So you can actually do all these measurements very nicely with that.
And when you're doing it for chin up and chin down, then you have to put the protractor on this side.
Yeah.
And when you want to do the third position, that head tilt, then it has to be in the back, or so that we can see. So you have to use your basic intelligence in that which measurement you're taking. Is it face turn to the right, left, or is it chin up and down, or is it a head tilt to the right and left? So all the three will have 3 dimensions, and the protractor has to be in 3 different dimensions.
Next one is, how do we differentiate the ocular versus non-ocular causes for a compensatory head posture?
Okay. So whenever you have a feeling that the person is having a head posture, first of all, you have to see whether it is a clinically significant head posture or just by chance. Because if you see in any group, you'll find people having a head posture. Sometimes they have just habitual, and they may be trying to listen more keenly, and they'll put a head posture. So that is something which is not necessarily a problem. So what you need to see is that with the head posture, if you are seeing that the eyes are straight, you just correct the head posture, and then you see that the eyes have deviated, then it is a clinically significant head posture. But otherwise, more often than not, many people will have an habitual head tilt or head turn. So all head postures are not always clinically significant. That's the one point that you have to remember, right? And if you have that, so what I said was that you look for the head posture, ask him to straighten his head. If he has a problem, now it will show up on straightening the head. Get me? So if there is, let's say, nystagmus, and if you straighten the head, the nystagmus becomes worse. Or if he has a paralytic squint, if you straighten the head, then you will see that the deviation comes up, which was neutralized by the head posture. So you need to see what happens on correcting the head posture. So that will tell you whether it's a ocular significant head posture or a non-ocular cause. People who have, let's say, a sternocleidomastoid problem, now they may have a head posture because of a mechanical cause. So if you straighten their head, now here there is a catch. Because of the tight collar muscle, you can't straighten the head. You will either cry or have a problem. So what you may then do is you may even tilt the whole body along with it. So the purpose is to correct the head posture. And in that case, if we have to shift the body also, it doesn't matter. But if you do that, you'll see that there is no deviation coming up. Whereas if there is a superior oblique palsy, there would be a hypertropia which comes up whenever you straighten the head and worsening on reverse head posture or the opposite head posture.
One clue also comes from asking the parents to send pictures of the child sleeping. Because, when they're not using their eyes, so whether it's nystagmus or ocular torticollis, it will disappear at night.
Good point.
But the sternocleidomastoid one, because it's organic, it stays.
Yeah, that's a good point. Yes, sir. Next one is, how do we differentiate pseudo versus true strabismus in cases with epicanthal fold or telecanthus? Like any pointers?
One is that you will first see. First part is observation. Second part I said was confirmation. So the confirmation is to be done by cover test. And if you had a feeling that, okay, the eyes were having an esotropia, you did a quick cover test and you found out that there was no deviation as such. Then you can do a correction of this telecanthus by just lifting or pinching the skin in front. And if you lift it, you'll see that the ESO disappears. This is very important to show to the mother, because they do not get convinced by your cover test. They say, no, but I see there is a squint. Oh, doctor, look, and when he is looking on the sides, he is having this esotropia. And that is something which is very difficult to explain to a person who is having this.
Yeah.
So you need to just pick up the skin and see that, look, this has got corrected. So then they say, oh, yeah, that's correct. So
yes, coming to that side, because it's very difficult to convince them. And I think they keep coming back again and again saying that it's a squint, and you're not catching it. So any pointers to counsel such parents, like just to reassure them?
It's a good thing. I normally get one of the parent to stand behind my shoulder to actually see the reflexes herself. I ask the child to be in the father's eyes. There's another thing I do is I do a Bruckner's. So I get a Hirschberg built in. I get the red reflexes coming up. I do a quick closure with my thumb, and then I have some interesting little toys which I attract the child and bring it close to his nose. And if I get good convergence and accommodation, which I can continue to see on my Bruckner's, so a child who can focus on the object continues to converge well is evidence of good macular perception, and the fact that convergence itself is a form of stress. And if the child can bring it in, he's got bifocal fixation. So that's, I add all these, and everything is over in 1 minute on a good day.
But the second point I would like to make is that even though you have confirmed there is a pseudo-esotropia in a child, always make sure that you call them again, maybe for a pretext of refraction, which is very important in these children. So ask them to get an atropine refraction and check again. Because at that moment of time, the child may not have had an esotropia because he is not accommodated. But if he has an accommodative esotropia and that shows up on your refractive assessment, then again, you would be missing if you had not looked for it. So pseudo-esotropes, the mother has said there was esotropia. You found it was pseudo-esotropia. Still, there may be an accommodative esotropia along with a pseudo-esotropic problem. Telecanthus patients are not going to be debarred from accommodative esotropia. They could still have it. So you need to give this credence to the mothers, because many a times mothers are right.
Also, there's another catch. Why I also call them, definitely a few months later, I ask them to show me again. Because for one thing, just in case you missed it, like in an accommodative situation, also true esotropia can come up later after your examination. And then the parents will say, oh, the doctor has already told us that this is only a feeling that we are getting. It's not really there. So it's always a good idea to call the child back.
And how soon the follow-up should be, sir? 6 months, 3 months?
Yeah, at least 6 months. I've got nothing much to lose. So if somebody comes at 4 months, I'm quite happy. They've shown me, a bifocal fixation, nothing there. Nothing, I will lose nothing much, even if there is some accommodative thing I've missed if he comes 6 months later.
And I think the last question for the day is, can you please explain about the determination of null zone in the case of nystagmus?
So, okay, we may be having another detailed topic on nystagmus, but just to give up briefly. So when we have a person having a head posture, which is abnormal, then we said we would be suspecting one of the situation would be because of nystagmus. And he has a null position in that particular gaze. So if he has an eccentric null position, he would have an abnormal head posture. And if you straighten the head, then nystagmus gets worsened. So in such a situation, what you do is you need to measure the abnormal head posture, and that may be important for our planning of surgery for shifting the eccentric null to the primary position. So this shift has to be brought back. And what we do basically in a nystagmus case is, in a way, surgery, squint surgery in each eye. One eye is ESO, the other eye is EXO. So I remember this because one time, I mean, the insurance people denied because they didn't have any column of nystagmus surgery. So they said, no, we don't have anything like nystagmus surgery. So I said, okay, list it as strabismus surgery, esotropia in one eye and exotropia in the other eye. So because in abnormal head posture, if he has a null, you will see that one eye is adducted and the other eye is abducted. The eyes are otherwise ortho, provided there is no associated ESO or EXO. In true orthos also, you can have a nystagmus. So in those cases, we say that, okay, we are correcting sort of ESO in one and the EXO in the other eye, so that we are balancing the eyes coming to the normal position.
So anything you would like to add, sir? Amitava, sir? Last question. After that, I think we can wrap up.
No, it's been absolutely covered. He's covered that question completely.
Yes.
He always does that.
Yes. Yeah, I think with that we can, I think, wrap up the session for today. Thank you so much, Pradeep Sharma, sir. I think you were really lucky so that you could like split the topic into two so that we could have like a comprehensive overview of such an important topic. I'm sure these two sessions are going to be viewed the maximum number of times by our postgraduates. Thank you, sir. And thank you, Amitava, sir, for your insights and valuable inputs.
Thank you once again, Shefali and Dr. Amitava.
Thank you, sir. Thanks, Shefali.
Next, we'll be meeting on August 17th. The topic is ESO deviations, the terminology, classification, etiology, symptoms, signs, diagnosis, and treatment, comprehensively covered by Dr. P. Vijayalakshmi. So see you all on Wednesday, August 17th. Have a very good evening.
Good night.
Bye.